Good afternoon to each of you, and thank you so much, Bob, for that kind introduction. I'd like you to email those talking points to my 3 children, please. Thank you all for being here with us this afternoon, either in person or I know we have a whole group that's virtual, and so it's just a pleasure to have each of you here. And I thank the foundation and Michael for allowing us to have this very important topic of health equity at the Magee Summit. Two topics that I'm so passionate about, Magee and women's health, and also health equity. I'm also so grateful to see so many of you in the room today, community members and colleagues who have joined us with your busy schedules for this important conversation focusing on the critical need to advance health equity, and it can only be done in partnership with our community. You know, COVID-19 taught all of us a lot of lessons, and it's been a great reminder for all of us that healthcare is an incredibly important asset and a critical institution to every community. And we need to continue to nurture it and ensure that we have the very best health care for all of our communities and for all of the populations we serve. As the new CEO of UPMC, I am so thrilled and honored to have this responsibility, and I'm focusing on 3 major goals that I'd like to share with you. One is the overall UPMC experience, how we deal with our patients, our members, and our employees. Secondly, the growth of our insurance division and our provider platform. And we have at this point about 42 hospitals and 4 million members who we touch each and every day. And then, of course, innovation and discovery, which is at the core of who we are at UPMC. And I am really focusing on ensuring equity, access, inclusion, and innovation in every one of these spheres. Everything we do for our patients, for each other, and for our members. In the area of racial disparities and inequities, we are making great strides toward integrating communities of color and patient voices into what has been the standard of care. However, we must continue to deepen our relationships with the underserved, with disenfranchised populations throughout the region and throughout all of UPMC. In fact, as an organization and as a community, we have an opportunity here and a tremendous responsibility to drive engagement, to dramatically move the needle forward in health equity in ways that set us on an accelerated trajectory. We have invited community leaders from throughout the Pittsburgh region who work side by side with those who are severely impacted by health inequities to join us here today, either in person or virtually. We have also invited national thought leaders, and we really appreciate each of you coming into Pittsburgh, as you have deep experience working in healthcare, in social justice, in health equity, in politics, or in academia. And it's important that we have this dialogue together. I would especially like to call out our 3 keynote speakers, Dr. Deidre Cooper Owens from the University of Nebraska-Lincoln, Dr. Ben Danielson from the University of Washington School of Medicine in Seattle, and Father Paul Abernathy, who leads the Neighborhood Resilience Project in the Hill District right here in Pittsburgh, Pennsylvania. A few words about the Disparity Committee. Bob already touched upon that. About 2 years ago, we launched this committee. We had been doing work in this area for years, but it just wasn't intentional enough. And so the board asked us to form this committee, and Diane Holder, who will be speaking to us later, who is the lead of our insurance division, asked me if I would join her, and we asked other thought leaders around the system, and knew that we would focus on 4 pillars to start: family medicine, maternal health and obstetrics, cardiology, and behavioral health. And we know that this is only the beginning. The work of the Disparity Committee, I'm just going to tell you our 6 priorities, and then I'm going to sit down and we're going to hear from our panel. Number 1, we are focused on building further trust and ensuring transparency. Really, really important, and we heard a lot of that from the community. And we hope that these conversations will help to bridge those gaps. Number 2, ensuring equitable health outcomes. Everything we do at UPMC needs to start and stop with a patient. We are addressing this on many levels as it relates to health equity, whether it's our unconscious bias as individuals or as a system. Number 3, embedding equity organizationally wide. And one of my primary goals for a number of years has been the work on the UPMC experience. And so that's where we are creating a culture where people want to work and want to stay. Having programs that scale, right? We could have small programs, but if we can't make them larger, we have 92,000 employees right now. You will hear from some of our speakers today who lead programs that are working. And we want to expand and collaborate with the community in ways that we can expand our programs to have the greatest impact. Number 5, measuring gaps. It's really important that we measure our success, action-oriented accountability, data-driven improvements. And lastly, and certainly not least, we want to continue to work with the government, with the state, with federal policy, on advocacy efforts. We are all in this together, and it is really important that we work together. We're very grateful that both Mayor-elect Ed Gainey and U.S. Senator Bob Casey will be participating virtually this afternoon. In spite of their very busy schedules, they understand how important this is, and they've agreed to join us. We also appreciate the Allegheny County Council member, Liv Bennett, who I know is here with us this afternoon, and Doug Jacobs, who is here from the Department of Human Services in Harrisburg. So thanks to each of you. The overarching goal of the session is to deepen the conversation around the persistent race disparities that still exist in our region. We need to further identify and expand those opportunities to work together, and if we work together, we can improve them. So in closing, I'd like to recognize a few other people, our 3 moderators today and my UPMC colleagues, Ellen Beckjord, Tracy Conti, and Dondra Jones, 3 amazing women who have all worked tirelessly in developing this session, and they will play a central role in ensuring a thoughtful, meaningful dialogue to help catalyze engagement and to move this agenda forward. It is only when we work together, collaboratively and creatively, that we can address these structural barriers to close the gaps and accelerate these solutions that will empower and engage our underserved communities. And that's what it really is about, to achieve health equity. It's not easy. This is not for the weak. So if you feel like you can't do this, you shouldn't even try. But I encourage all of you who are here today, because I know you want to do this, share your observations, express your opinions, don't be afraid, and bring forward those ideas about how to build a better path forward. We actually need a superhighway, not just a path. Together, that's what community engagement is all about, and with that, I thank you. So now, do I ask the questions? Okay, great. This is fun, asking the questions. All right, so with my colleagues here, I'm going to ask Dr. Conti first. If you could describe, where do you see us today in family medicine?
Yeah, I think we're at a really exciting time in family medicine and primary care as we look to decrease disparities, to increase equity. It really starts in the community level, and that's where primary care and family medicine is. We have to ensure that we are that voice that brings innovation in primary care models to the community, but also can listen to what the community says and how we provide that care. In family medicine, as we care for the whole entire family, regardless of what setting, whether it be in their home, in the office, in the hospital, we can provide that level of intuition, that level of innovation in that care for our patients. And so it's really exciting a time, especially as we move this path forward, as you said, to talk about equity, to really bring it to the table. And I think the voice of our communities is so central in the care that we provide. And as family medicine, we want to be the people that do that.
That's great. And just so everyone knows, family medicine cares for patients from what age to what age, Dr. Conti?
From birth until their death. It's really cradle to grave care, and again, across the settings. And that's so important because we see patients where they are. We can look at the opportunities and see where those disparities occur, whether that is with food insecurity, whether that's with transportation, whether that's with housing, because we travel along the journey. We see families. We get to understand patients from a family level that allows us to care for them in a different way. It's not in a piecemeal, but really that comprehensive continuity of care that we can provide for our patients and their communities.
Thank you. And Dr. Conti is our new chairperson, our chairwoman of family medicine. So let's have a round of applause for Dr. Conti.
Thank you.
Okay, Bob Edwards, you're up next. I'm going to ask you a tough one. Where are we today in maternal health? And maybe you can explain that.
So maternal health is the care of women and their infants, ensuring a healthy pregnancy and therefore a healthy delivery and newborn child. And we've done a lot of introspection around maternal health. Most of you are aware, Magee-Womens Hospital is not just a hospital, it is a brand. If you go to a meeting internationally or nationally, every single meeting I've ever been to, someone comes up to me and says, I was born at Magee. This could be in San Francisco, Washington. Was one meeting I had in Europe, actually. Somebody said that. But we've kind of rested on our laurels a bit. We thought, well, we have this great facility. We are doing world-class care. A mile from Magee, we have some of the worst outcomes for maternal health in the country, 1 mile away. And so we clearly failed in some way in our methods and how we've addressed the needs of the community. So I propose 3 things we need to do. One is our workforce. We need to engage our workforce. We need to have our workforce come from the communities that are underrepresented and underserved, so we have a better understanding of the dynamics between our hospital and that workforce. Tracy Condi and some of the other speakers you're going to hear later this afternoon have done this extremely well. They're very well engaged. Obstetrics is just learning the ropes on that. But one of the things we've really prioritized is increasing the racial diversity of our workforce. You know, when I was a resident here in the 80s, we had Bob Kisner and Morris Turner and Bob Thompson, and they were the force for taking care of black women. And they were passionate, and they worked hard, and they worked late, and they worked frequently. And that's atrophied away. And so now we can't rely on a few physicians that are very passionate to deliver that care. We need to figure out a better way to do it. So we need more racially diverse individuals as part of our workforce, both on the nursing level, but also on the physician level. We need to improve our access. We need to partner with the community. We can't just sit down in Magee. We have to do what Tracy's done, what Conrad Smith has done, go out in the community and work with our community health centers. And we're working on that. And in addition to that, we need to shepherd our patients as they enter into for their OB care. And that is the community health worker that works with OB patients called the doula. You're going to hear more about doulas likely this afternoon and later in the week. But our doula program has really shifted the tide. We've taken members from the community, engage them in our workforce team, and they work outpatient and inpatient. We paired that with new technology to increase access. And finally, and I think Dr. Schuster, the medical director of the health plan, will speak to this, we need to look at the finances of this. Women are burdened financially, and when they do have medical illnesses, they need to have the safety that the financial safety net will be there to care for their illness even after their child's delivered. We identify many comorbidities in women during pregnancy, but the ability to cover their care after the baby's delivered and to provide convenient access to them, we're still working on that. We think technology and doulas, among other things, will help to initiate that. I'm very excited about the future, and I'm very excited about what we're going to talk about today.
Thank you, Dr. Edwards. That was terrific. So, Dr. Schuster, who is our Chief Medical Officer of the health plan, what do you see as the gaps? Why is this not happening?
Yeah, so thank you. So I've been thinking about gaps really both from my perspective at the health plan and also my background as a psychiatrist, and have just a couple comments about each of those. So from a health plan perspective, I think a couple of the items that we can really focus on were raised by Dr. Edwards. One is really trying to increase the diversity of the workforce. There's lots of people in our network. And as the largest insurer in Allegheny County, we can definitely have an impact on who's available to see, who's available to see your patients and our members. And there's lots of literature now that indicates that if people see someone from their own background, they're likely to have better health outcomes. So we've redoubled our efforts to really try to make sure we enroll a really diverse network of people to serve our members. But there's a limitation on that, because there's a limitation in terms of actually who's available to be enrolled in the network. That we really need more minority and a more racially diverse workforce. So we're really eager and engaged in trying to support efforts similar to what I think you'll hear about later today in terms of trying to engage people as young as high school students from underrepresented communities in healthcare so that they can pursue that as a career. Second is we really have an opportunity to engage community-based organizations that have a strong focus on serving underserved communities. We really are fortunate in Pennsylvania to have strong support from our Pennsylvania Medicaid program through the Department of Human Services to really contract with community-based organizations, and the department under Dr. Jacobs' work has really led efforts to create regional accountable health councils that brings health plans, health providers, and community-based organizations together to better serve our communities. And then from a behavioral health perspective, there were a couple themes that I thought are worth mentioning. One is the issue of stigma. So probably no group of patients has ever had more stigma than people with chronic behavioral health disorders. But there's been an effort to really address that now for at least probably 3 decades. And there were recently surveys during the pandemic that show that a majority of the population in the country, a significant majority, really now sees behavioral health disorders as an important problem that we should develop significant resources to. And that's really a dramatic change from when the work started. The populations we're really talking about trying to better serve today also suffer from significant stigma, and we need to put similar efforts towards them. And last is really the theme of what we're really trying to do ultimately is change the culture we work in. Mm-hmm. You know, there's lots of content work to do, but we also really just want to change how people think about the work and the importance of what they do. And that's not something we can accomplish in a year. I think often what we do concretely impacts and changes culture, so we have an opportunity to do that going forward.
Those are great ideas. Thank you for sharing that. And then last but not least on our panel, we have Dr. James Taylor, who is our Chief Diversity and Inclusion Officer and Chief Talent Officer. And I always tease him about his name because he is a rock star, but he's not the original James Taylor. So I guess my question for you, Dr. Taylor, is what do you see as our path forward?
Sure. The path forward, at least as I see it, is multifaceted, right? I think the path forward begins with continuing conversations like that which we're having today. We need to recognize where there is opportunity for us to do more and for us to do better. But I will also say that conversation without action is a lost opportunity. So how do we leverage the richness of the talent that resides within this room, that's listening to this august brilliance that resides in this room, and what do we do with it, right? How do we turn that conversation into action so that we're creating change throughout our beloved community? Secondly, we've got to be clear on our why, right? Why we're doing this work, right? This is to improve the health of our community, right? I will oftentimes say that we don't want diversity just for the sake of being diverse. I believe in equal access, I believe in equal opportunity, but we don't want diversity just for the sake of being diverse, but we recognize as a community, as a city, as a county, as a society, that the more diverse we are, the better problem solvers we are, the better critical thinkers we are, and the more healthy, vibrant community we're able to have throughout our community. Third, I would say that we need to continue to identify those systemic, structural, ingrained, biased behaviors. If you respond to anything with, we do this because this is the way that we've already done it, or the way that we've always done it, then I would say we've got to check ourselves on that, right? We've got to look at our approach and our why and our processes that allow us to become more inclusive in our practices. And we need to identify these barriers throughout our neighborhoods and throughout our health systems and throughout different aspects of our communities. And we do this. It's important that we do this because we recognize, and we've known for some time, that medical care accounts for 10 to 20% of one's overall health outcome, right? But it's various factors that make up the other 80 to 90%, that include individual behaviors, that include socioeconomic conditions, that include environmental factors. And so we know that health equity is a team sport, y'all, right? It's a team sport in which we need to be clear on what's the role of the provider, what's the role of the community member, what's the role of the pastor or the rabbi, what's the role of the community in increasing and improving the health of those that we want to provide better health outcomes for throughout our community.
Well, thank you. Thank you very much. Let's have a round of applause for all of these panelists.